And I would now like to introduce Dr. Mark Burkhardt, the new director of the University of Iowa Healthcare Holding Comprehensive Cancer Center, which is the keynote sponsor for the summit. Welcome, Dr. Burkhardt, and welcome to your very first Iowa Cancer Summit.
Thank you. Oops. Thank you. It's a pleasure to be here and to introduce our keynote speakers today. I just want to say a word about my 2 weeks of experience in this role. I am excited to be here and part of the Holden Cancer Center because of the fine work done over 25 years and more, where Dr. Wiener and a committed group of faculty created the infrastructure to achieve NCI designation and maintain that over the years. And what I've also seen here that I've been very impressed with is the links to the community and the opportunities to build on that. And this collaboration between and sponsorship with the Iowa Cancer Consortium is part of that. Because, if our mission is, and it is, to defeat cancer and to serve the entire state of Iowa as the Cancer Center, we can't do that alone. There's a lot we can do together and need your help in prevention, in screening, in care delivery, and in survivorship. And so I value the community collaboration and links because we need to do everything we can together. So thank you for the opportunity to introduce our keynote speakers. I'm honored to introduce our opening speaker, Dr. Kimryn Rathmell. Dr. Rathmell was sworn in as the 17th NCI director in December of 2023. She previously led the Vanderbilt University Medical Center as physician-in-chief and chair of medicine. Her research and specialty are focused on hereditary kidney cancers, and she has done foundational work on the drivers and genetic causes of kidney cancers and the opportunities to develop better treatment approaches for this disease. Her research has been very productive with more than 250 articles. And these were in top journals that we all have heard of: New England Journal of Medicine, Nature, Journal of Clinical Investigation, and others. Dr. Rathmell spent quite a bit of time in Iowa, as I understand. She achieved her undergraduate degrees in biology and chemistry from University of Northern Iowa. Go Panthers! I don't know if I'm supposed to say that now that I joined the University of Iowa. And her PhD was in biophysics and an MD from Stanford University. She's the recipient of the 2019 Louisa Nelson Award for Woman of Achievement, Vision, and Inspiration, and the 2019 Eugene Schonfeld Award from the Kidney Cancer Association, and the Paragon Award for Research Excellence from the Doris Duke Foundation. She was a leader in the Cancer Genome Atlas kidney projects, and she was a winner of the 2020 American Association of Cancer Research Team Science Award. She served in the NCI Board of Scientific Advisors and the Beck Foundation Scientific Advisory Board. She has leadership positions, or has held them, in the American Society of Clinical Oncology and American Society of Clinical Investigation. She also has received the honors of being elected to the Association of American Physicians, the American Academy of Arts and Sciences, and the National Academy of Medicine. So thank you for joining us, Dr. Rathmell.
Well, thank you very much. It's a real honor to be here. I want to thank Kelly for the invitation. And when I asked if I could visit some other places in the state, I've gotten to do a good road trip, and I've had a really good time. Just to that was a great introduction. So thank you very much. I wish my mother were here to hear that. But again, I'm Kim Rathmell. I use pronouns she, her. I'm about 6'1" and have short, straight brown hair. I got a haircut in Spencer, Iowa yesterday. So what I want to do is mostly today listen and learn. I'm, as you heard, coming up on my year anniversary at the NCI, and I think one of the biggest things that we can do is really understand the needs for cancer across America, and Iowa, of course, has a great special place in my heart, but also is really central to literally central, but is central to the United States. So I wanted to share, when I first got off the plane in Cedar Rapids on Friday, got in my rental car, it was tuned to a station that I knew that was playing the same music as when I left here in 1991. And then the first commercial I was so impressed by was an oncologist in the Cedar Rapids area in a 30-second bit talking about lung cancer screening, who was eligible and how to get it done and why it was important. It was really well done and sort of set the stage for my whole trip to show how much people really are invested in getting this right and moving the needle. So I think it's also important to think about, how much what we do in Iowa can shape the community, and things that we can do really well and do right can make such an important difference. So my goal today is to learn from you, to learn how we plan to work together in the future, and really to be inspired to action. So my agenda today, I'm going to tell you a little bit more about myself, just so that I think that can help us as we move forward in those agendas. Talk about how we're doing as a nation in cancer, to talk about some of our NCI efforts in cancer control, to talk about the National Cancer Plan, which fits really well with the Iowa Cancer Plan, and the Cancer Moonshot, and then hopefully have a little bit of time for Q&A. So this is a little bit about me. So I was a town kid. I'm from, I call myself from Sheffield, Iowa. I was born in Omaha, Nebraska, but spent a few years in Woodbine, Iowa, and southwest Iowa, and then around 5th grade or so, moved up to Sheffield and was there through the rest. So I lived on 7th Street, which was on the edge of town. So there was a field behind, and my dad raised bees because that was a great place to do that. I walked beans, I detasseled corn. I was a typical Iowa kid growing up. And that experience really helped to shape, where I kind of have my annual cadence. I still come back in the summer. I come back in the winter. I really miss the fall. So thank you for holding this in the fall, because it's been so nice to see, the corn coming in and, the beautiful fall colors. And but when I think about fall, and I think about sort of growing up here in Iowa, a lot of what I think about is small town football. So I was a band kid, played tuba, but football in Sheffield, Iowa, there were the football players. The people came out to cheer for the cheerleaders. You bought at the concession stand that was supporting the Rotary and supporting, other parts of the community. That there was the kids in the band. Literally, in a town of 1,000, pretty much everybody comes to the football game. And they came there, and it's cold, and you cheered on your team because that's what it meant for the community. And it was important in the case of the school football team supporting the kids, but it was the community always rallies around and brings people together. And so to me, that's what I think about in terms of Iowa. People show up. And so this is where we can make the same difference when it comes to cancer. I feel like that when I talk about the National Cancer Plan from the NCI. It's important that we show up in all of the elements, and I'll go into that in some detail later. A little bit more about sort of where I come from. So I'm a physician scientist, somewhere I think that's on there. So how did that start? So I told you that I was working in the field, so that's hard, and it's hot, and so I got a different job. Sheffield, Iowa. What do you do there? So I got a CNA certificate, and I worked in the nursing home in Sheffield. I started there. I got it before I could work as a CNA. I worked in the kitchen first when I was 14. When I was 16, I became a CNA and worked there all the way through. That gave me the introduction to health and the interplay between health and illness. And I really loved that work and taking care of patients, and really thought I would go on to work in maybe geriatrics. But I went to the University of Northern Iowa, bent on going to medical school, and had a wonderful advisor who introduced me to the idea that we can discover things that are not known. And I did research on soybeans. The little leaflets the picture came from me telling my writing team, what do soybeans look like? Like they have like these two little leaflets and they bend with the sun. And anyway, so that was a project that I had, was studying soybeans and studying some of the pesticides and how they impact the soybeans, and very relevant to many of the conversations that you're going to have today. But for me, the discovery was that there was more to discover than was in the textbooks. And we could do that at a much bigger scale. And that's what took me on this journey, to marry the discovery part with the medical part. So thank you, Iowa, because all of that put it all together for me. So my roots, though, come from, again, the community and what I said about football games. We all show up, but we also listen, and we listen to everybody. In Iowa, we listen to farmers, we listen to teachers, we listen to truck drivers, and we listen to grandmothers, because they know their business and they know what they're doing. And that is where I think we can be most powerful. Now that I'm sitting at the NCI, is if we start to listen a whole lot more to what is what other people have to say about the experience that they're having and where this is. So that's why I'm here, and that's why I want to be a part of this. And I represent all of the NCI. It is not just me. We all want to be here and listening. In cancer, we do listen to constituents and patients and communities, but one of the things that I'm trying to move toward is that we don't just listen, but we engage, and we are all partners in this together. I just wanted to give one more little personal example as well, which is comes from, where's the Spencer group? I know they're here. There you are. That also comes from Spencer, and I shared this yesterday. I don't think they knew this, but I had some time when I was at Vanderbilt, where Vanderbilt bought a bunch of small hospitals around us, and then they just tell the department chair and the physician in chief, figure that out. How we're going to start to integrate and work together across these small hospitals. And so the resource that I had was my brother and his experience at Spencer, telling me more about things that I didn't know about how you make a hospital work in a small town, and how you get the medical care that you need, and how the best communication strategies could actually be implemented. And so it was that sharing that really helped us to be able to work with our own hospitals. So we can share across all of these spaces. We can learn from things that are, scrappy solutions, or things that really lean on the community. So that's me, and that's how I come to be here. Okay, so let me just tell you, you saw some of this in really a beautiful talk leading up. This is a great time for cancer. We're doing a lot of things right. So this graph in the yellow shows the decreased mortality rate from cancer. So year over year, we're seeing fewer people dying from cancer. That does mean we have more survivors from cancer. That's a great thing. But we need to do this even better. How is it that this has gotten better? Lots of good work in screening, lots of good work in prevention, novel therapies like tumor-infiltrating lymphocytes for melanoma. So we're seeing new and innovative therapies, and it's no longer one or two drugs coming from the FDA that might be a Me Too, things that we couldn't get that excited about. There is something exciting coming out in every different cancer type every week. It is really a different kind of world, because the biology, the genetics, the drug discovery is coming together in a really exciting and powerful way. Now, how do we actually translate that to real reality is one of our bigger challenges. There are lots of challenges ahead. This is just one example. This is the rise of cancer in people under 50. Cancer doesn't sit still. So we're seeing trends that change. Trends here in Iowa as well. And so we have to be able to be at or in front of changes rather than catching up really late. The rise in cancer in people between the ages of 20 and 50 has been going on for decades and really wasn't recognized very clearly until just a couple of years ago. But why is that happening? Something that we need to address, just like we need to address what's happening here in Iowa. And it's complicated. It's going to be reaching out to communities that have previously not been recognized, and it's also going to be working together across spaces that we didn't before. So, some challenges. I'll just put a few lists. So these are some of the things that I stay up worrying about at night. We still don't have enough basic science for many cancers. We have a lot of basic science, and I just told you how excited I am about what we've got, but there's still a lot that we just don't know. There's not enough data for many cancer types. There are a lot of cancers that are rare, that don't fit the mold of the big common cancers, and we don't have enough information there. We don't have enough good information on how to use AI safely and effectively. We know it's got potential. We know there are things that it can do to help with the workforce challenges that are ahead of us, or things that we need to have answers more quickly, or the big spread of information that comes across a nation as big as ours. But we need more information there. There are huge bottlenecks in clinical research. It shouldn't be acceptable anymore that it takes 3 years or so to develop a clinical study, 3 more years to accrue the patients, and then a few years of analysis. Those 6+ years are more than people have, and we have bottlenecks that we can and have to break down. And then having a population that's not represented in our workforce or in the populations of patients that we study. That makes our data less robust, that makes our understanding less comprehensive, and it erodes the trust of populations that we're trying to reach. Okay. I just wanted to throw in one why, and Dr. Charlton's talk really set this up well. When I was treating patients more actively, I may go back to treating patients, so I don't want to say back when, but I'm taking the year off from treating patients. As a medical oncologist, I don't think I ever had a patient who didn't at one point say, why did this happen to me? And I almost never could answer that. I can think back on maybe 5 times that I had a conversation where I could answer, I think I know why. Even when the answer was that they had a genetic predisposition. But otherwise, we don't know why. So this is way more complicated. Why on a population is the cancer incidence rate so high in Iowa? And we need resources from the state and federal level to explore that why in a whole lot more depth, because there are answers out there. As complicated as it is, we'll have to sometimes break it into smaller, clear chunks, and sometimes look at it as a whole and figure out what we can on the why so that we can take action with the what. And those population-based studies addressing common risk factors, and so that's already been set up very clearly, can improve our prevention and our screening strategies. Okay, so let's talk a little bit about where we are on a national level and how we're doing. So things that are on the right track. So this all comes from the Healthy People 2030 cancer goal that basically is creating a report card. So we need a report card so that we know what we're doing right, can do that more, do that better, and what we're not, so that we can focus and bring the rest up. So things that are on the right track. You already saw overall cancer death rate. And some of the biggest gains are from the cancers that you just heard are some of the biggest problems here in Iowa. Lung, colorectal, breast, and melanoma. So making a big difference in the big ticket cancers is where we can move the needle most effectively. The incidence of colorectal and lung cancer also improving on a national level. Screening, really becoming part of the normal practice of healthcare for colorectal and breast in particular, but we need to make a lot more improvements for other cancers. And then overall cancer survival rate. Where are we lagging in the incidence of other cancers like prostate, breast, and melanoma? In screening, I already mentioned this, cervical and lung cancer. We have good screening opportunities there, and those are really lagging. Sun protection and sunburn among adolescents. Raising awareness of cancer risks and symptoms, and when to take action, and when to call a doctor, and when to prioritize health. And alcohol consumption, as you already just heard. So I just want to recognize that your efforts are really all on the right track. The efforts in cancer control from the Iowa Cancer Consortium are really inspirational and for sure things that I'll take back and talk to people about back at home, so we can find out how well we're doing this in other states and how we bring some of this connection further. The Iowa Cancer Plan, the Iowa Cancer Registry, congratulations on 50 years. Actually, I guess 51, is that right? Yeah. This ability to monitor progress and challenges and creating stronger networks, this is where we have to go in the future to make a really big difference. Okay, so what are we doing at the NCI that you might find interesting? So these are some activities that are related to some of the main cancers of concern, sort of the big tickets. These are big national programs, but that I want you to be aware of. In lung cancer in particular, one I'm really excited about is the Pragmatica lung trial. So this trial takes two standards of care and compares them to each other. It's an important study for being able to provide the right care to the right patient and bringing the right personalized care to individual patients with lung cancer. What I'm really excited about this trial is that we worked with the FDA to try to figure out how to make trials less complicated. And this trial stripped away every unessential piece, took those consent forms that used to be 50 pages long and made it 9 pages. It took away a lot of the eligibility criteria that we all know you really don't care about. And it took away a lot of the language and the extra tests that you're like, why is it that we need to do a CAT scan on this time? We wouldn't normally do that. Don't do it, right? So we took all of that out, and the result is that the trial is accruing like 2 or 3 times faster than we had expected. So we will get the answer faster. So this is back to it took a while to develop this trial, but it's going to be accrued in 1.5 years instead of 3 years. So that's one kind of thing that we can really make a big difference at. The Prosper Lung Study is a lung cancer screening study that went through the same cleaning role of taking away all of the unnecessary details. But we'll answer the same questions and get us faster to the information that we want. In prostate cancer, we're using AI. AI is showing up in all different kinds of areas, but we're supporting work grading prostate cancer biopsies, analyzing MRI scans, and detecting potential cancerous areas so that we can more effectively tell someone what their risk is or where they are in their prostate cancer journey. In breast cancer, the TMIST study, which has been going on for a very long time, comparing 2D to 3D mammography, will complete this year, and we'll be able to offer people knowledge about whether we need to use one or the other, or if they're equally comparable. And work that discovers whether and put this one in here just because we just did a Cancer Currents blog. I encourage you to sign up for the Cancer Currents blog if you want to see what's going on at the NCI, but showed how does breast cancer get the signals that it needs to grow? And it turns out nerves provide a lot of that. We'd always kind of suspected that there was an interaction, but this group showed some very nice data to understand that better. And in melanoma, I already mentioned, using tumor-infiltrating lymphocytes so that we can really harness the immune system on a different level to take care of people with melanoma. Whoops, there we go. So this is the theme of my talk, which is, and I know I'm deep in Iowa State territory here in Ankeny, so I had to put Iowa State on here. There's a lot of Iowa people. I didn't put Northern Iowa, just even though that's my team. But that when Iowa wins, we all win. Okay, so I really want you to take that home and know that that's how I feel as well. Is that I want Iowa to win, because when Iowa wins, everybody wins. So that we can learn from each other in how we do screening more effectively, in how we manage prevention, how we talk about things like binge drinking and smoking cessation. That we're all on the same team and can use our cancer plans to make forward progress, to bring cancer control into communities, and to know how we all work in this together. Sorry, lost my card. Okay, so now, how do we end cancer as we know it? So I used to get that question a lot more when I first started. So that's sort of the mantra of the White House, is that we're going to end cancer as we know it. So what does that mean? So I had to think about that for a minute. So what does it mean to end cancer as we know it? It does mean reducing mortality. And our goal is to reduce mortality by 50% by 2047. But it also means to change the experience of cancer. And so I want you just to imagine for a second for Iowa, what it would mean if we had in Iowa that cancer was not a burden, or that cancer was a manageable disease, or that most cancers were prevented or detected early, and that fear was not associated with cancer, or that everyone knew their personal risk for cancer, and that high-quality cancer research or care was accessible to everyone, and that people with cancer live long, healthy lives. So that's what I think is ending cancer as we know it. That's a future state of how cancer can be a part of it. It is a phenomenon of our health that will be with us. But how we approach it, how we know how to tackle it, how we talk about it, and whether or not we fear it or feel confident in what we're doing is the difference between where we are today and where we could be tomorrow. And if Iowa feels that, then the nation will feel that as well. So I already mentioned that our cancer moonshot. So the second iteration of the cancer moonshot outlines 2 goals. Those 2 goals, decreasing cancer mortality by 50% by 2047. I've already shown you that we've decreased by 30% over 30 years. So that's just tweaking that line down a little bit more. I'm pretty confident that we'll get there, even doing things that we're doing today. The better screening, the better treatments that are out there, that one is something I actually feel reasonably confident that we'll achieve. Not if we just stop, okay, so don't stop what you're doing, but that's on the horizon. But improving the experience of people and their family living with and surviving cancer, that's where we get to ending cancer as we know it. And so there's a lot that we have to do that's beyond our drug discovery efforts, understanding biology, which is near and dear to my heart, absolutely essential that we do, but being able to work on survivorship, palliative care, helping empower patients to know what kinds of questions to ask, and working on developing better relationships between academia and community and reaching rural America, where patients are receiving their care and being able to provide the experience for them that everyone wants to have. So how we do that, I do want to let you know that it's not just a lip service thing. There's also, I get a lot of questions about but there's no money behind this cancer moonshot. I agree. I wish there were money behind this cancer moonshot. But what is very powerful is this cancer moonshot has a mandate that all of government is involved. And so the Cancer Cabinet, which you can see here, includes all of government. And so in a way that really has not been easily accessible before, the door is open, and we work very closely with the VA. So as an example there, we had a project to accelerate clinical trials in the VA population, which was very effective and has become sustainable even outside of NCI funding to reach a population that's nationwide and can be a model for things that we can do in other places. But we also work with the CDC. We work with the FDA very closely on how we're doing clinical trials and thinking about new ways that clinical trials can work so that they are not as cumbersome or as narrowly focused. We also work with the Department of Energy. All of this AI-generated work that we want to do requires supercomputing power that none of us have, but the Department of Energy does. And so we work really closely with them on some of these newer AI algorithms. We also work with the Indian Health Service. I have one example up here called Smoke Free Native, working on reaching communities that have previously been underserved and therefore have different rates of cancer than their neighbors. And lots of other fun ones, even NASA. So we have projects that go up to the space station and help us learn how cancer develops and how we can treat cancer effectively. I could go on, but the open doors of the Cancer Cabinet is worth a lot of money and allows us to do a lot of things that we couldn't do before. And we do that so that we can achieve the goals of the National Cancer Plan. So our National Cancer Plan is only a little over a year old, which is a little bit surprising, even to me. But I've found it to be incredibly valuable. It has 8 goals, and all of those goals happen in a foundation of discovery and science. So I like visual representations, and so I took those 8 goals and created more of a graphical abstract. So it has a platform on which discovery science is a part of every one of the goals. The intent of a national cancer plan is to move forward, and so that's why the chevrons are there, showing forward momentum, because our intent is to get to a place where we have improved health outcomes for everyone and we meet the Cancer Moonshot goals. So what are our goals? 4 of them are health-centric. So I cluster them together because they are a continuum for the patient experience. Preventing cancer, detecting cancers early, developing effective therapies, and delivering optimal care. That includes survivorship. That's the whole care experience. And so that's a whole package for what the patient experiences of the cancer of the cancer effort. So you could say, well, that could just be our plan because that's what we want to get better. But we can make that much better. We can accelerate or enhance it by empowering those goals with 4 empowering goals. And those 4 empowering goals: maximizing data utility. You can see where using data here in Iowa helps us understand, helps us achieve each of those goals. But also eliminating inequities. There's a lot of low-hanging fruit in reaching communities that have too high of incidence rates that make sense, or who don't have good access to healthcare. And that example from Waterloo is really striking and gives you an area to focus on and something that where there's a difference that can be made. Optimizing the workforce. This is not something that we can do without people power. And we need a workforce all across that space, from scientists, epidemiologists, but doctors, nurses, and healthcare professionals, healthcare workers across the state are essential to be able to deliver on this campaign. And then the empowering goal that I like most is the one that surprised me the most when I saw the National Cancer Plan come out, and that's engage every person. But to me, that's the one that has the most power, because every person has some risk for cancer. Every person knows someone who has cancer or has experienced cancer. Everyone has a personal story and a personal stake in this. And so by realizing that this is not a problem for the scientists, and this is not a problem for the doctors, and this is not a problem for the politicians, this is a problem for everyone. And we're all a part of the solution. So that's our National Cancer Plan, and it meshes just beautifully with the Iowa Cancer Plan. So areas that we can collaborate and where we can really work together. I want to just point out rural health, a very high focus for us, in particular because one of the first things that I was charged with in this role was to bring better cancer research to communities outside of academic centers. So where is that? That's rural America. So I'm learning a lot from you and spending time trying to make a difference in this space. We have an ad hoc working group. I think I have a slide that's going to have this in just a second. So I don't want to get too ahead of myself. So I'll tell you about that in just a second. But we can learn from all of those different components of government and from people in communities to be able to make a difference in the lives of patients with cancer. We can innovate in clinical research innovation, and we can build capacity. I just want to go to the slide because this is what I keep wanting to talk about. That's why I'm stumbling. So forget that one. It's all the same. So these are some tangible things that we're doing at the NCI that are addressing some of the problems facing rural America. Our Rural Cancer Control Program is a program that is looking at barriers to prevention, to screening, to treatment, is working on options that increase access, that address financial toxicity and financial burden, and even are addressing some of the questions around transport. We had a breakfast this morning where that came up as one of the major parts of challenges for patients in Iowa. And that is a part of the Rural Cancer Control Program, is understanding where there can be solutions and how to understand how we can best implement those. One of the things that I started when I first got into this group is a working group on community capacity for clinical research. This is drawing on all of the different expertise that there is out there in communities. So we're working across NCORE sites, our National Community Oncology Research Program, and the American Cancer Society is a partner in this, and bringing together groups that are working together today. ASCO, the VA, CMS, other components of HHS are working together to see where there are opportunities for us to bring more clinical research or advances in clinical care into communities, whether that's implementation science or distributed clinical trial design or ways that we can do more virtual work. All of those things are going to be on the table, and this group will be bringing those back to us. And just the process of them talking to each other has already opened doors and allowed things to move much more quickly. So their final report will be coming out, or probably a midterm report, because there'll probably be more after, will be coming out in December. I'm really excited to see that, and we'll publish those thoughts and results. The Clinical Trials Innovation Unit is one thing that I want to let you know that we're really excited about. This is where we got Pragmatica Lung and the Prospect Lung trial. So this is basically, I call it a kitchen table, and it's got clinical trials, investigators, the heads of our cooperative groups, the FDA, and patient advocates. And it's an opportunity to rethink how we do clinical trials, to talk about what are the opportunities to do clinical research in a different way that meets the needs of patients and communities. And so I very much would welcome ideas that we can take to that kitchen table and bring to different clinical trials. And then the Virtual Clinical Trials Office. So this is brand new and first opens its doors in January of this year. So the Virtual Clinical Trials Office came from the pandemic experience, where we had to do a lot more of our work virtually and realized that some of it could be done virtually. And it's also a pilot project that's born from necessity, which is that we don't have enough of a workforce for clinical trials. There are not enough people out there to do patient enrollment screening, to do data collection, to do some of the regulatory work, to do consent work, to do some of the questions that patients might have about the clinical trial, either at the beginning or in the middle of the study. All of those are things that people can do in a virtual environment. And offering that as a service was something that we thought we would test the waters in and see which of those services were actually valuable. And we're learning a lot about that. Where is it complicated or easy? And how can we provide services that people need, whether it's in a large academic center or in a rural community? So this is 6 sites to start with, so successful that we're already bringing on 3 more. And the goal is to make it a normal part of how we do clinical trials as we learn how to do it best. So just a few examples. So I'm just going to wrap up, and then I will try to save just a couple of minutes for questions. Again, my theme, when Iowa does well, everyone notices, and everyone does well too. So I think Caitlin Clark probably exemplifies that the best for today, right? So, when Caitlin Clark was here at Iowa, I never had so many friends who knew where Iowa was or what Iowa did or were following Iowa sports and continue to follow her, right? So now she's in the WNBA and people still follow. And now the WNBA is a big deal and women's sports are a big deal. And I was back in Cedar Falls and my father-in-law was watching women's volleyball. We couldn't stop watching women's volleyball. So, the ripple and the impact of things that we do here in Iowa have big impact, including, so back in 1984, a bunch of girlfriends and I went to see Barry Manilow in concert in Ames, Iowa. One of our moms had to drive us because we weren't 16 yet. And so when he came to Des Moines in August, we all had to go again. And so, and we were really thrilled. So this has even permeated Barry Manilow, who wore Caitlin Clark's jersey at his concert. So I got to witness that. I would say up and close and personal. You can see we had kind of bad seats, actually. So, but that's the theme. When Iowa does well, everyone does well. And so that's where I want to take this. So we're all in it together. A win for Iowa is a win for our nation. You're a significant part of the nation's cancer effort. The National Cancer Plan, the National Cancer Moonshot, and what we do at the NCI. And there's so much we can learn from each other. And another thing that I like to say is, we don't have time to be patient. Our patients are impatient, and we have to be impatient for them as well. So with that, thank you very much, and I will take any questions if I have time.
Yep. Yeah, we have time. We have time for questions. We also have virtual attendees. So if you have a question, please raise your hand and we'll bring you a microphone. And if you're a virtual attendee, you can ask questions in the chat and we will read them for you. So, yes.
Thank you.
We need a microphone.
We're going to put chat questions first, and then I'm going to take this online.
Okay.
Sorry.
Can you guys hear me decently? Turn it up a little. Okay, cool. Thank you. So we have one question in the chat from Natalie. And Natalie says, I have had patients who are not wanting to know their numbers or risk of cancer due to fear of not being covered by health insurance or life insurance. Is this part of the plan for patients being more informed about their risks in screening to not discriminate on risks for coverage?
Yeah, that's an excellent question. And I think it hits on a couple of things. Like one is the fear, and some of the fear is founded, some of the fear is unknown. And in that example, part of the fear might be that they just don't know what's covered and what's not. And not for lack of trying, probably, because it's not always abundantly clear. So how does that fit in our National Cancer Plan? Absolutely, that's a part of trying to understand how we can help with financial toxicity. We can push for things that involve transparency, as well as helping to make sure that screening is appropriately covered. There's always a lag that I can't help with, but making sure that ultimately things get covered. So in our professional budget justification, we had to give 4 topics that we were really going to push hard on, and financial toxicity was one of them. Even though that's particularly hard for us, but we just can't ignore it, because if we develop all these amazing screening tools and treatments and then people can't get them because of the financial burden or the financial uncertainty, then we've done no service to anyone. So that has to be part of our thinking.
Thank you. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center here in Des Moines, Iowa. So we're a comprehensive community cancer center. And I'm proud to say we're also part of the NCORP. So the National Cancer Institute Community Oncology Research Program. As you know, 85% of cancer patients are treated in the community. So having that ability to do cancer research in the community is just great. And we really appreciate the NCI's program. Also, as part of that program, we are doing cancer care delivery research.
Yep.
So as you know, not all research is drug A better than drug B. And to kind of build on the last question, we're also seeing patients with huge financial toxicity. And as we get into these various Medicare Advantage plans, huge increase in pre-authorization, and trying to get studies done requires, by studies I mean medical studies, can take days, if not weeks, to get authorizations done. So as we look at cancer care delivery, you said it very well, it doesn't matter if we come up with another drug that might cure cancer if we don't have access to it. What will the National Cancer Institute do in helping to lead this financial toxicity, this issue that we have of the barriers to getting prevention, the barriers to getting screening, and even people with really good insurance, the barriers we have to efficiently get patients into treatment and then provide survivorship care, considering where we are in the payment of cancer care.
Yeah. So it's no secret that our healthcare system is, some say broken, at least very challenged, especially with fragmentation and being able to reach the care that we want, which may be in multiple different centers or in ways that don't easily fit all of the different forms that are required for the payment. So, I think our biggest focus area has been on uninsured and underinsured, and working with idea states and thinking about how we reach populations that don't have insurance. But I think you're absolutely right that it's insured as well, where this can be prohibitively taxing or expensive, or both, probably mostly both. So I think, what is the NCI doing? We're trying to, work with sites to be able to understand more and do, some of the implementation science that can help make things a little bit more streamlined. That's a big area that we can help in. But we're open to trying to help in any way possible. So I'm very much open to suggestion. And I just want to make a plug for the NCORE program. To me, that's a real gem of the NCI that is largely unnoticed, and what it can offer for treatment studies as well as cancer control studies is really valuable. And I'll just, another plug for it is that virtual clinical trials office that all came from an NCORE site that was doing it on their own, and then told us, this is how we're making it work. And so we learn a lot from you as well.
Hi, Dr. Rathmell.
Oh.
Thanks for being here today. I'm Jess Skorslitz. I'm an assistant professor, and I pulled a reverse U. I trained at the NCI, and now I'm here, so I went opposite. I'm an investigator who does clinical trials. I do exercise clinical trials, and as you know, the administrative burden of clinical trials is quite high. Even though I'm dosing exercise, it's at the same level as if it were a drug. I really admire the mission for inclusivity and more clinical trials. As an investigator, there's an extremely high burden for submitting these types of applications. And then further, for community engagement, there's these high standards and rigidity for inclusion and exclusion criteria. Further, Forms H just sunsetted, and now it's Forms I for clinical trials. Are there any initiatives to reduce some of these administrative burdens to help make clinical trials more accessible and easier for early stage investigators thinking about community engagement for these types of studies?
Yeah. I'll give you a few examples, although every time I get into one of these, I realize that there's just like a mountain more, and your examples are illustrative of that. So first, I'll say trying to think where I'm going to start. So first, AI can help us with a few things. So we're working on piloting where AI can make consent forms simpler and bring them into some normal, sensible amount of material to read. I'll be completely honest. My sense is that this bloat has come partly from a lot of copy paste and like if it worked here, it must work again. But also, the people who write contracts shouldn't be the people who write consent forms. And while we all open up our phones and get a big long thing that you just scroll to the bottom and click accept, that's not really what you want to do when you're signing up for a cancer clinical trial. You want to be able to know what's going on, and sifting through a 50-page document actually doesn't necessarily help you feel better about it. So making the language simpler, making it be only what's needed and relevant, we have tools that we can move to that, and the FDA is very supportive of that, including a little executive summary at the top of clinical trials. So we're piloting that in some places to make it really simple to read. This is the gist of what you're going to get in the next 9 pages, because we probably can't make it a lot shorter than that. So that's one thing. This next one was so hard to do, so I'm going to tell you, even though it'll feel really small. So our NCTN, our National Clinical Trials Network, is groups of somewhat regionally defined clinical trials groups. They all used different forms, and so if you were trying to open one group's trial, but you were in another group, you had to transpose it to another form, and there was a lot of headache about approvals of forms. There's only one set of forms now, starting in January, and it's modular so that people don't have to recreate their form every time. You just on and off click on what you want and what you don't want. I'm very, very excited about this. And it took a lot of work, but it's very, very teeny. So, but there are a lot of things like that we can do. And the thing that I've been most impressed by is how much the FDA has been supportive. There's always the FDA says. The FDA probably did say things 10 or 20 years ago, but they are much more open to common sense answers today. So.
I think that's all. So
okay.
With that, I'd like to thank Dr. Rathmell for being here and taking questions. And we'll take a break and reconvene here at 10:35. Thank you.